A very good morning. My name is Kausalya Devi, and my assignment 2 is based on Addison's disease. My group members are Renisha Selvakumar, Susanti Nair, Darshni Devi Thevarajan, and me myself Kausalya Devi Kandasamy. I'll be presenting the case study 1, which is Addison's disease. The summary of my case study is that a 33-year-old young man complained of weakness in severe degree where he had insufficient food and medications. He had several complaints of postural dizziness, fatigue, and many more. For his previous medical history, he underwent treatment with isotretinoin because of severe acne. He also had hypothyroidism, so he took levothyroxine. The patient was referred to endocrinologist due to some disabling problems during the assessment, and upset of stomach and general arthralgia were noted from the patient. The patient was also admitted to the cardiology ward because of sinus tachycardia of 120 beats per minute and the rest of 120 beats per minute while walking the hallway. He was also diagnosed with some mental illness which is from depression, anxiety, social phobia, and also was treatment with some medication with that. For his family history, his mother had anemia and also hypothyroidism. His pressure was also recorded, but his body temperature and glucose level was normal. As for the background, Addison was the first person to describe the adrenal insufficiency and the deceiving appearance of it. It begins at the adrenal gland, which also causes deficiency in cortisol hormones and aldosterone. Compelling characterizations such as discolorization of the skin, loss of appetite were easier to recognize, yet still some are not diagnosable. Even after few years, which are centuries, there are still difficulties in finding clinical presentation. As for the case study 1, the case presentation is a 33-year-old young man alerts an ambulance because of a weakness in severe degree that intake of food and medication has been insufficient for some time. His symptoms was fatigue, postural dizziness, and social isolation, which was like depression and anxiety. For his previous medical history, he underwent treatment with isotretinoin, which is for acne, and also he had hypothyroidism. He was referred to the endocrinologist because of he had some disabling problems. He had depression, social isolation, and also excessive sweating as well. But the patient was also admitted because of his sinus tachycardia, which was mentioned prior, 120 beats per minute at rest and 190 beats per minute during a stroll or corridor, which is really bad. The patient also had few episodes of anxiety.
Greetings, madam. I'm Darshni. Now let us look into the investigation for case study 1. So, in the case of the infection being a precipitating factor, the patient initially received a large dose of hydrocortisone without delay, together with IV crystalloids and antibiotics. The patient then undergoes a head and chest CT scan without any findings and then shifted to the intensive care unit, where he received a norepinephrine infusion for the major cardiovascular collapse he encountered. It reaches a maximum of 1.0 microgram per kilogram per minute, as well as full dose of milrinone in addition to the already mentioned fluid, which is hydrocortisone, for his infection. And on a closer examination, the patient exhibits few symptoms such as hyperpigmentation on typical locations such as his palms, vermilion borders of the lip, knuckles, together with sacral pressure of ulcer. Shortly after the admission to the intensive care unit, the patient underwent an echocardiography signaling heart failure with an ejection fraction of approximately 15 to 25%, and terminal prototype natriuretic peptide reaches a maximum value of over 35,000 nanogram per liter. On day 4, the patient exhibits clinical signs of a successive cardiovascular improvement, which is confirmed by repetitive ultrasound screenings. And after 3 weeks following the adenoid crisis, the cardiac function in the patient seems to be fully recovered. And on day 6, the patient regains consciousness and extubated. And on day 8, he was finally recovered and discharged from the intensive care unit. Now let us look into the differential diagnosis of case study 1. So initially the patient was also diagnosed with hypothyroidism based on the similar symptoms of that exhibited by the patient. He was also diagnosed with vitamin K deficiency due to the low level of serum albumin and elevated prothrombin time. Anorexia nervosa is also one of the differential diagnoses for this patient. And after examining again the morning values of serum cortisol and plasma adrenocorticotropic hormone, it showed that it is over 10 times the upper limit of reference age. Thus, the diagnosis of primary adrenal insufficiency was also confirmed. And the subsequent measurement of autoantibodies 21 hydroxylates distinguished the cause of an autoimmune adrenalitis. And some of the common causes for this autoimmune adrenalitis are adrenal insufficiency, infiltrative diseases, or malignancy, and even some certain other conditions. And the screening for celiac diseases and also abdominal CT scan seem to be normal. Now let us look into the treatments for case study 1. Some of the common treatment that the patient received is initially he received a large dose of hydrocortisone without delay with intravenous crystalloids and antibiotics. He also received norepinephrine infusion for his major cardiovascular collapse, which causes him to have the revert back the situation. Next, he also received levothyroxine for his hypothyroidism and acetylcysteine infusion for transient ischemic hepatitis, and also continuous treatment with hydrocortisone and no corticoid for primary adrenal insufficiency.
As for the outcome of follow-up, after the medication, the patient was discharged. It took about 5 weeks. After 11 months of the crisis, patient went to a normal state, no longer needing home care service. Patient's psychiatric state has improved considerably after the hydrocortisone therapy. Increased state of psychiatric illness, but the only concern about the patient is that they couldn't sleep well, so they required a mirtazapine drug from the physician. This case illustrates the case of adrenal crisis, which was harder to recognize since the symptoms were insidious to the patient and physician. They were having hard time to diagnose it. The medical history of the patient illustrates the symptoms might have appeared for as long for a 10 years time period. The symptoms were postural hypotension, syncope, arthralgia, diarrhea, fatigue, psychiatric disorders. The morning S cortisol's values were measured both 6 and 8 years before the adrenal crisis, but regrettably without concurrent ACTH evaluation. The cortisol values were allegedly merely screening samples at the same time, and the level of suspicions were regrettably low. The possibility of not diagnosing this disease were high since the value were in normal range. This situation shows that the interpretation of S cortisol were hard and the adrenal crisis should not just be based on some random values. It is advised to confirm the diagnosis using the gold standard ACTH stimulation test unless these outcomes are clear-cut. The long-term signs and symptoms of mineral corticosteroid deficit in our patient included postural hypotension caused by volume depletion as well as electrolyte problems. The treatments should be delayed parenteral administration of 100 mg hydrocortisone, additional 200 mg hydrocortisone distributed over the coming 24 hours. They also had fluid replacement and also electrolyte correction. The recovery will be faster as the medications are effective. Regarding to the patient, the medical history of our patient and the reduced but still considerable titers of 21 hydroxylase and autoantibodies indicate that the disease has been present but undiagnosed for a year length of time. This story is only one of several that illustrate the difficulty in diagnosing Addison's illness. It is commonly confused for psychiatric conditions including depression, apathy, anxiety, or even psychosis, and it's already clear from Addison's original description of the cases that these characters frequently precede other symptoms.
Learning outcome from case study 1 is first, regardless of any ill patient admitted to the hospital, if he or she is presented with any adrenal crisis such as cardiovascular collapses, he or she should immediately receive and be treated with 100 mg of hydrocortisone intravenously. It is also important to make sure that that particular drug is in low cost and doesn't involve any diagnostical measures. Second, patients with non-specific symptoms such as fatigue, postural dizziness, weight loss, gastrointestinal manifestation, or psychiatric disorders are susceptible to chronic adrenal insufficiency. The condition should not be ruled out by a single cortisol measurement. Last but not the least, An elevated TSH might be a sign of Addison disease. It should be noted that the thyroxine therapy can precipitate an adrenal crisis in these individuals, so it is better to treat early before the situation went out of control. So, in conclusion, from the case study 1, we can clearly see that the patient is recovered fully and the treatment that is provided to the patient is also successful. He becomes more concerned about his disordered appearance and even reconnects back with his mother after many years of being silenced and muted. This is one such example of the hardship and difficulty that the healthcare professional faces in diagnosing Addison disease, since it is very commonly mistaken for psychiatric disorders such as depression, anxiety, psychosis, and even apathy. Since it is a very rare diagnosis and can even be life-threatening if it is not diagnosed and treated properly, it is important to be careful in minding all the necessary signs and symptoms exhibited by the patient in order to give a proper treatment. That's all from me. Thank you.
Hi everyone, my name is Renisha and I'm going to be presenting on case 32. Now for the summary, a 63-year-old Nigerian woman complained of progressive weight loss, nausea, easy fatigue, and skin discoloration that was getting darker in over an 8-month period. She didn't have migraines, blurred vision, or bowel habits change. Evaluation and medical history found no abnormalities in determining the cause of her illness. 10 days after being admitted, she experienced nausea, vomiting, and fever with chills. And eventually, she advanced remarkably and was followed up after being admitted for 4 weeks. Now for the background. Thomas Addison first described the clinical features of primary adrenal insufficiency in 1855. This syndrome occurs when the adrenal glands do not function properly and do not produce enough cortisol hormones, hence the name Addison's disease. I think this case is important because the hallmarks of Addison's disease sets it apart from other types of adrenal insufficiency, which are brought on by either pituitary or hypothalamic illness, causing decrease in ACTH hormone secretion. And autoimmune and tuberculous adrenalitis are the most frequent causes of Addison's disease. Hemochromatosis, metastatic neoplasia, and fungal infection are some more conditions that causes Addison's disease. In locations where tuberculosis is endemic, it is indicated that TB should still be taken into account when determining the cause and diagnosis of adrenal insufficiency. Now for the case presentation. As mentioned earlier, the symptoms shown by the patient are increasing darkening of the skin, dizziness, easy fatigue, nausea, occasional vomiting, and progressive weight loss. The signs are low level of plasma cortisol as it was undetectable at 0 to 30 minutes of corticotropin administration. CT scan of abdomen showed a non-enhancing oval-shaped left suprarenal mass with calcification and an ipsilateral hypoplastic but functional left kidney. Now for the investigations. A few investigations were done in order to conclude the diagnosis. Firstly, the patient was examined physically. Main findings were pulse of 106 beats per minute, which is regular and small. Blood pressure is 160 mmHg supine and 70-40 mmHg when sitting. The apex beat was normal and funduscopy revealed normal fundus. All other systems were essentially normal. A clinical assessment showed normal red cell morphology. Fasting blood sugar was 76 milligram percentage and total serum protein was 7.8, which is also considered normal. And corticotropin was administered intramuscularly as a rapid screening test of adrenal function, whereby plasma cortisol was undetectable from 0 to 30 minutes after its administration. Radiological diagnostics showed normal liver, spleen, pancreas, and pelvic organs. CT scan of the abdomen showed a mass on the left kidney, which confirms the diagnosis of Addison's disease. A CT brain scan was also done, which showed normal. Next is the differential diagnosis. Since Addison's disease is also called primary adrenal insufficiency, whereby adrenal glands don't produce enough of the hormones cortisol, a related disorder is secondary adrenal insufficiency, which happens when your pituitary gland doesn't release enough adrenocorticotropic hormone, ACTH, which activates your adrenal glands to produce cortisol. So another similar disease to Addison's disease is Cushing's disease. Cushing's syndrome happens when your body has too much cortisol, which is hypercortisolism, and your body has too much of the hormone cortisol over time. So this can be due to taking oral corticosteroid medication or due to overproduction of cortisol in your body. So too much cortisol can cause a fatty hump between your shoulders, a rounded face, and pink or purple stretch marks on your skin. It can also result in high blood pressure, bone loss, and occasionally type 2 diabetes. If it is left untreated, it can result in exaggerated facial roundness, weight gain around the midsection and upper back, thinning of your arms and legs, easy bruising, and stretch marks. That's all from me. Thank you.
Hi, so I'm Susanti here. So, related to the treatment for the case study, so 10 days after the patient has her admission and she has a few treatment, and the treatment was anti-tuberculous drugs. They undergo give her an intravenous fluid, which is dextrose in saline. They gave her anti-malarial, antibiotics, and also hydrocortisone, which is a steroid. So after undergo this treatment, she remarkably recovery was reported, but she was maintained with oral prednisolone and also fludrocortisone. So the outcome and the follow-up of the patient was, after 4 weeks of the admission, after a few treatments also, the patient condition was totally stable and remarkable progress was reported. So they discharged the patient in a medical outpatient, which means to a normal ward. And also, in the initial of the admission, the patient had 3 episodes of Addisonian crisis after the initial admission, which is at the hospital. She got acute malarial attacks, she got upper respiratory tract infection and also gastroenteritis. But she was fully recovered and also resulted with no neurological deficit, but she has treatment for other symptomatology. She also maintained with oral prednisolone and also fludrocortisone, but she was having a daily anti-tuberculous medication. Also, the discussion part and also a brief review of the case, which this is a case report of a Addison's disease, which is in a Nigerian female patient, that draw attention to the condition prevalence in this setting and also educate healthcare professional about its potential etiology, particularly in this time of tuberculosis and also the HIV and AIDS. So, it is in a pandemic where this patient came up with a symptoms of increased darkening of the skin, which is known as a hyperpigmentation, and also she had a diseases. She has a drastically weight loss and also fatigue, but there were no headaches, there were no blurred vision, there were no loss of consciousness or bowel habit, but she remained in a good health with lightening of the initial hyperpigmentation and also treatment of other symptomatology. So she had progressed in a good health after she has few treatments undergo in the hospital. So the learning points and also the take-home messages that we can learn from this case study or this kind of situation is, patient with Addison disease, they does not only affect their physical condition or also affects them emotionally, but also affects them emotionally and also mentally. It is not as easy as we think to overcome every phase of life with this disease, yet one has to mentally and emotionally prepare in such many ways. For example, they can exercise regularly, they can meditate and also do some yoga for their mentally to be fit and also emotionally, and they should get someone to talk so that they can get advice from them and also put an effort to have a daily healthy routine in their life. So they have to have this mindset where they have to think positive to overcome fear in any situation, and it is also advisable for them to attend for a cognitive behavioral therapy. So, in conclusion, related to the Addison disease and also to this case study, we can conclude that this disease can be managed by medication or any other alternative therapy such as yoga, exercising, or cognitive behavioral therapy. So that's all from me. Thank you.